Assalamu alaikum. My name is Dr. Faisal Karim. I'm working as a senior registrar at Shalamar Hospital in Orthopedics department. So I have a presentation for you today. So that's about the extremity trauma. That's a part of our trauma course, right? So let's start. So what are our objectives? So in this lecture, we'll be looking at the initial management, damage control orthopedics, fracture management, dislocations, open fracture, how to apply a cast and how to splint a patient, cast care, compartment syndrome, and what is crush injury and a fat damage. So there are different types of injuries that you encounter when you are dealing in the emergency department. That can be fracture, dislocation, open wounds, and you can have a compartment syndrome or a patient with a crush injury, and you can have even patient with amputations like in TOCA injury or glass injuries. You can have a nerve injury and other tendon injuries as well. What is initial management plan? So as you have in your previous lecture seen the primary and secondary survey. So our slide will be related to the arthro-related primary and secondary survey issues. Okay. So in the primary survey, you should identify the life-threatening injuries so that you can better manage your patient. So these can be pelvic disruption, femur fractures, and major arterial injuries or crush syndrome. So there can be bleeding in case of open fractures that can be dramatic, but it might not be life-threatening. So it's the job of the team leader so that the team is not distracted and you identify the life-threatening injuries first. Okay. So pelvic injuries. So this is the X-ray that is showing the normal anatomy. You should know the anatomy first. These are the hip joints, both. This is the pubic symphysis. So you have to see for this area. And this is the iliac blade. So you have to see any fracture line in there. And these are the sacroiliac joints on both sides. Okay, so you have to look in these areas for the fracture. This is the neck of the femur. You can have fracture here. These are the pubic and ischial ramus. You can fracture here. So what's the issue with the pelvic fracture? So there can be hypotension associated with it, and there's very high mortality. If patient has a hypotension with the pelvic fracture, the mortality is very high. So you have to then stabilize your patient. Okay, so there are different ligamentous structures that are holding the pelvic in place. So the injury can lead to pelvic trauma and the other hypotension injuries. So these are the sacroiliac, sacrospinous, sacrotuberous ligaments, and the muscles of the pelvic floor. So what's the mechanism of injury? So there will be a high energy trauma, of course. So there can be a motor vehicle crash, a motorbike accident, or a vehicle colliding into a patient, or there can be fall from the height. So there are different injuries. So there can be anteroposterior compression, lateral compression, and the vertical shear injuries, or there can be a combination of the above three injuries. So this is a anteroposterior compression. So just know there are three types with the increasing severity. In type 1, you can see there is a ligamentous injury of the pubic symphysis, but this gap is less than 2.5 centimeters. And this is a minimal damage to the patient, and this can be managed conservatively. But if you go to type 2, there's a more severe injury, the gap more than 2.5 centimeters. And there's also involvement of the ligaments, anterior ligaments complex. Anterior sacroiliac ligaments are disrupted, Okay. And there is external rotation of the pelvis, and the pelvic volume is increased as a whole. So there will be a more chances of hypotension in the anteroposterior type 2 and type 3. In type 3, whole of the ligaments of the posterior ligament complex are gone, along with the pubic symphysis ligament. So there will be more chances of hypotension in type 2 and type 3. So you have to look out for this. And what's the lateral compression injury? The lateral compression injury is something hit from the side. So the pelvic volume is actually reduced, and hypotension is a least of our problem here. The most problematic thing here can be injury to bladder or urethral injury, because if we have fracture here and this piece goes inside, like in type 3, then the bone spikes can injure the bladder. And you have to look out for that, and you will need the help of a urologist. And in the vertical shear injury, patient have a usually fall from a very high, means 12 feet height or more. So you can have a limb lengthening on the normal side and the limb shortening on the opposite side, because the pelvis have moved upward on one side. So how will you manage the patient? So you will require a combined team effort from general surgeon, orthopedic surgeon, and a good anesthetist. If you have a patient that need to be operated, and then the general surgeon will do his work. If there is associated bone injury, the orthopedic surgeon will apply the X6 or the plating. And if there is a bleeding problem, then you need the help of an interventional radiologist or a vascular surgeon. So they will help you out in that case. But if you don't have high-tech facilities and patient is stable, then you have to move him to a trauma center. So what are the simple ways to control the hemorrhage? This slide is very important. So simple ways, if you are in emergency, you have no help, you have to just stabilize the patient and move him to the other setup. Then internal rotation of the lower limb. So it will decrease pelvic volume, and a pelvic binder. Okay, and if you have vertical shear, apply longitudinal traction along with it. Okay, so you see, this is the X-ray before the application of pelvic binder. Then after pelvic binder, you see pelvic volume is reduced and fracture almost reduced. So this is a pelvic binder in place. And if you don't have a pelvic binder, a simple sheet, you can apply a simple sheet and use the clamps. And what's important, the level at which pelvic binder is applied, it's at the level of the greater trochanter of the femur, proximal femur, okay? So you apply the binder at that level. And these are the X-rays of a patient that have an external fixator in situ. And you can see staplers. So patient might have a laparotomy. And yes, patient had a laparotomy. So in case of patient laparotomy, you have to apply the X6, okay, to stabilize the patient. So angioembolization, that will be done by the interventional radiologist. And the pre-peritoneal packing, if embolization delayed or you don't have an interventional radiologist, it will be done by the general surgeon. And if fixation is needed, then you need an orthopedic surgeon. The mortality rates are very high. You can have, generally there is 1 in 6% mortality rate. So you have to be vigilant, you have to be on toes and manage it, okay? So there is damage control orthopedic term. So you show there three terms: early total care, damage control care, and early appropriate care. So we'll go through them one by one. So for this, you have to know the systemic inflammatory response syndrome. That's a response out of body to the injury. That can be sepsis, that can be trauma. Okay, so there's a cytokine storm that is actually for the betterment of the body. But if this response is too high, then it can lead to organ dysfunction, organ failure, and even death. So a systemic inflammatory response that is controlled is good, but uncontrolled response or too much response is bad. So first aid. When you have a trauma, it's the first aid to the body. So our inflammatory response will be like that. Okay. And with time, it will decrease. And this line is the fatal line. So the response will not cross that. If it goes to that line, that can be very fatal. So this area is death from multiple organ failure or adult respiratory distress syndrome. And what is second aid? Patient had a trauma, and then you do the surgery. That will also increase the response. So you see, this is the secondary. So this response was going to be like that, but due to surgery, inflammation again, cytokines, and then this is going down. So this response should be well below this area, okay? So that the patient does not die and he has a recovery. So this is the bad response. Timing of surgery is very important. If you do the surgery early, when the patient is still recovering from the first hit, or then the secondary response of the second hit will be too high, the patient can die. So what's the early total care? So basic, it's a care that should be done within 24 hours, and that can be fixation of all long bones. If patient have any visceral injuries, that should be dealt with. But this can only happen when the patient is stable. You cannot do this in unstable patient. So in the unstable patient, you have to do the damage control. So damage control is a term, there's a naval term. So when a ship is damaged, you do the minimum and you keep on. So damage control, what's it? You control the bleeding. If there's life-threatening injuries, you deal with them. And if there's a long bone fracture, you apply X-fix, binder, cast, and you stabilize the patient. And when patient is stabilized, then you do the definitive surgery several days later. So this is the paper in which there are various factors that should be kept in mind to which patient should be dealt with damage control orthopedics and which patient is a good candidate for the total care. So injury severity score, pH, temperature, a lot of factors are involved. So stable patient, we go for early total care. Unstable patient, we go for damage control. And this is the borderline. There the question lies, what should we do, early or damage control? So lactate level is a very good measure that can help us identify which patient to go for damage control and which for early total care. So 2.5, that's the magic number. If the lactate level is less than 2.5, you go for the early total care. And if it's greater than 3, you go for damage control. But if it's between 2.5 and 3, then you have to cater your care individually for each patient. So if a patient is stable, then you go for surgery. If he's not stable, then wait, stabilizing, then you go for surgery. So best day after damage control to do the definite surgeries between day 6 or 8 or even later. Between day 2 to 5 are not safe because cardiac output is high, inflammatory markers are raised. The second hit of the surgery could be fatal. So this is a table that showing the things that I have told you. See, stable patient, lactate less than 2.5, early total. Borderline, you resuscitate, and then you assess the lactate and you see whether the patient is stable or not. Then, if stable, then go for early total care. Unstable, then damage control. Lactate guarantee, damage control. So this is a term early appropriate care, that you see the patient, stabilize him, and then do the surgeries accordingly. Okay, the second it is important. So second hit of the surgery that should be done according to the patient's stability. Now, the bilateral femur fracture. So what's the issue in that? So when there is fracture of femur, or you can have a blood loss of 1.5 liter in closed fracture, and true bone fracture up to 3 liter. And what's the total amount in the body of blood? It's 5.5 liter. So more than half of the blood is lost in the space. So you can have hypotension. Also, you can have pulmonary complication from the fat embolism. When you fracture of a bone, the bone end move if they're not stable. Then the fat in the medullary cavity that's mobilized, that's absorbed in the bloodstream, and then it goes the lungs. So you have to look for that. So these patients should have a early fixation, either external fixation if patient unstable, or definite fixation if patient is stable. And he should be in a trauma center. So what's the fat embolism? You see the CT scan showing both lungs with the involvement. So there is a classical triad: confusion, shortness of breath, and skin rash, fatigue. So you have to look for that. Patient will be short of breath. Oxygen saturation will be reduced. You will have hypoxemia. And along with that, sorry, the light was coming. And the patient can have neurological impairment. That's why patient have confusion. They might be rash. So this usually happens within first 24 to 72 hours. And in case of a fracture of long bone, pelvic fracture, right? So there was a paper, they did a 10-year study to see which symptoms occur with which frequency. So these are the symptoms that I have already told you. So this was the percentage that they were found. Hypoxemia in 96% of the patient, and patient had tachycardia 93% of the time, and increased temperature in 70% of the cases. Unexplained anemia. Anemia, why? Because you have a blood loss. Long bone fracture, blood loss, patient will have anemia. So what could be done? Early immobilization. That's the key. And the corticosteroid, there's a controversial role. So the vent should be on standby. Give oxygen therapy to the patient. Patient have a good hydration. Okay. Thrush syndrome. Thrush syndrome is seen in the patient with injury to the muscle. So injury to the muscle, what will it release? It will release a myoglobin. It's a protein in the muscle. That myoglobin can go into the kidneys, and that can block your renal tubules, leading to acute renal failure, shock, and can culminate in the death if not treated. Okay, so what abnormalities you have is a metabolic acidosis, hyperkalemia, hypocalcemia, and DIC, disseminated intravascular coagulation, that can be life-threatening. Clinically, you will see the urine color will be amber color urine, and CK level will be more than 10,000. Okay, and myoglobin assay is a confirmatory test. So we will advise CK level, creatinine kinase level, and myoglobin assay. What's the management plan? So aggressive IV fluid. If something is blocking your kidney, then you have to flush it out. So you will give aggressive fluid. You will keep the CVP line. You will check the blood pressure. You will keep him hydrated so that urine output is good. Okay. And you can also alkalize the urine. That is achieved by giving bicarbonate and osmotic diuresis. So, what are the causes of the major hemorrhage to the patient? Patient can have a penetrating injury or blunt trauma that can lead to a fracture or a dislocation. Okay, and the arterial injury can happen in any of these. So, you will have to check the distal neurovascular status. In case of the arm, you will have to check the radial pulse. And if that's the case of thigh or leg, you will have to check the dorsalis pedis and the posterior tibial in the foot. So what will be the finding? They will be bleeding and pulse can be lost. Okay, cold, pale, extremity. If there's a hematoma, if there's a close fracture along with the vessel injury, there can be an expanding hematoma. What to do? If you have open wound, okay, first of all apply manual pressure to the wound. And after that, if not resolved with this, you can do a pressure dressing. Use stack of gauze and do a circumferential pressure dressing. And if bleeding is still present, you can apply a tourniquet. But the tourniquet time should be noted. Okay. So what are the pressure? In the upper limb, 250, and the lower limb, 400 mmHg. And how will you manage the injury? So if you apply a tourniquet, you will document the time of the tourniquet application, and you will consult the orthopedic surgeon or the general surgeon if you are suspecting only vascular injury. Or if you're suspecting bony and vascular, you will contact both, or you can have a vascular surgeon in it. Okay. So if you don't have facility, you apply the tourniquet, you stabilize the patient, and you move him to the center that have that facility. So application of a clamp is not recommended. If you have a bleeding, you don't apply blind clamps. Okay. So if you have bleeding in the leg, you have to stop the bleeding by pressure, and you can have a proximal control by putting a pressure over the femoral artery and vein. Okay. And if there's a fracture or dislocation, you have to splint it. And what if you got a amputated limb, hand, or a leg? So it's a traumatic experience for the both patient and doctor too. And you can have a tourniquet application. You will consult the trauma surgeon. Okay. And if you have a stable patient with isolated limb injury, you can consider reimplantation. So how will you save the limb and move him to the center? So you will thoroughly wash the limb, put him in the isotonic solution like vinegar lactate, then wrap it in a sterile gauze. Okay, then put that in a towel. That will be put in the plastic bag so that water is not contaminating it, because we will put that limb that has a plastic bag over it in a crushed ice to maintain a cold temperature. It should not get freezed, but it should be cold enough to preserve it. But if you have an unstable patient with amputation, then you have to see what you have to save, limb or life. So life is more important than the limb. Then you will save the life of the patient. Secondary survey. Now you have done the primary survey, you have dealt with the horrible things, and now in the secondary survey, what you will do? History, examination, okay? any other related injury that you might have missed in the primary or secondary surgery. You will see for that. So mechanism of injury is very important. Was it a history of fall? Was there any accident? Okay. And if there was accident, how the vehicle collided? Either it was from the front or from the side, the history of fall, what was the height from which the patient fall? Okay. Because when a patient fall from height, what do you see? You see the calcaneal fracture, long bone fracture, you can have a lumbocervical spine fracture. So you will have to see those things. So this is also showing the same things. If explosion occurs, there can be three types of injury. Primary blast injuries from blast waves. And from the debris or fragment of the blast is a secondary blast injury. And the patient was thrown due to the explosion to the other objects, that will be a tertiary blast injury. While examining the patient, ideal is to completely undress the patient. Okay. And what you will see? You will see skin, any break in the skin. Okay. You will assess the neurovascular structures, movement of the limbs. Okay. If the hands are moving, foot are moving, and you will check the distal pulses, radial pulse, pulses of the foot, and you will see there's any ligamentous instability if you're suspecting a joint injury. So likewise, you have read during your third year, fourth year, final year. So what you will look? Look, feel, move. So look for color of the skin, perfusion, any deformity, any swelling, any bruise, any open wound. Okay. And when you palpate, you can have a tenderness. Okay. So if you have suspicion of fracture, you will palpate it and you will feel that there is a discontinuity of the bone, but you don't have to move it too much, because it will cause the pain to the patient. Also, it can frequent mobilization can lead to fat embolism. So, limb-threatening injuries, ischemic vascular injury that can threaten the limb. If you have open fracture or a joint injury, then that limb can be damaged. And you have to see the patient is not having the compartment syndrome, or there was a dislocation or fracture and the nerve got injured. So you have to look for that too. So first of all, in that, you have an open fracture. Okay. So if there's a fracture and there's a wound, so it should be considered an open fracture. Okay. So for open joint injury, you can have an intraarticular gas on CT scan. Or if CT is not available, you simply put a saline and then you will see you can put a dye in the joint and you can have an X-ray. And if the dye is present in the joint, the wound is communicating through the joint and it need to be washed. So this is a classification of open fractures. Okay. So you have already read it. There are three types based on the size of the wound, contamination, and fracture pattern. And you can how to manage the open fracture. So you have to remove the gross contamination. Okay, you have to describe the wound. If there's fracture, you will splint it, and you will determine if there is any associated vascular injury. Okay, if there is an injury, you will consult the surgeon or the orthopedic surgeon, and it should be dealt with. And in the case of the open wound, antibiotic coverage is must. That should not be delayed more than 3 hours. It should be given within 3 hours. And what's the choice? You got cephalosporin first generation. But if the patient is allergic to that, you can give clindamycin. Okay. But if there's severe soft tissue injury along with bony injury, then you have to add gentamicin. So what the last thing to remember? If you have a farmyard injury, okay, a soil injury, so you will have to add piperacillin or tazobactam, okay? And that's not related to the wound size. Even the smaller wound, you have to give piperacillin or tazobactam to reduce the risk of the infection. So now compartment syndrome. So what's the compartment syndrome? It's the increased pressure in the compartment of the body, like forearm, like calf muscle. So what could be the causes? Compartment could increase in size. So ligaments are, so there's a covering around the muscles. Okay, so that cannot expand. But if there's something inside that will increase the size, that will put pressure on the muscles. So bleeding into the compartment, severe crush injury, burns, even excessive exercise can lead to compartment syndrome. And what can decrease the compartment size? So something compressing from outside, okay, like a tight dressing or even tight POP can lead to the compartment syndrome. So what are the sites? See, lower limb, forearm, these are the most common. The less common are foot, hand, gluteal region, and thigh. And what's the diagnosis? So the pressure is usually more than 30 mmHg of the compartment, but the pulses are usually palpable. The major sign is pain out of proportion. Okay, pain in the passive stretch of the muscles, and there could be paresthesia involved. Okay, absence of pulse is a late finding, so don't go looking for that. And you have 6 hours to deal with it. And if you're suspecting it, consult your consultant, and the fasciotomy should be done within 6 hours so that the blood flow to the muscles is revived and the limb is saved. These are the pictures. So you can see a fasciotomy done. This is the leg wound. This is the arm wound. Now the neurological injury that are associated with the secondary to fracture or dislocation. So the nerves are more near to the bone at the level of the joint. So if you have a dislocation of the joint, you can have an associated nerve injury. Okay, so you have to check the neurovascular status of the patient. And if you find a nerve injury, then you have to assess it in a progressive manner so that to see whether the injury is recovering or not. And if a patient is a compartment syndrome, then sensation will be altered and you won't be able to get a good look whether it is involving the nerve or not. So the progressive changes must be documented. If the fracture or dislocation, the dislocation should be reduced and fracture should be splinted with a backslab or cast. So this is a table that's showing various nerves and what type of injury is associated with. So ulnar nerve that can be associated with an elbow injury, like radial nerve with distal humerus shaft fractures. And in the lower limb, you can have sciatic nerve injury in case of posterior dislocation of hip, okay? And tibial nerve injury in case of knee dislocation. The peroneal nerve is located on the lateral aspect of the knee. So you can have that injury in case of fibular neck fracture or compartment syndrome. And these are the different findings that you will find. Now, a little bit about the dislocation. So this is the X-ray showing anterior dislocation. So there is an anterior inferior dislocation of the shoulder joint and how to reduce it. So this injury can happen anywhere. So you should know about it and you can reduce it if you give him a good painkiller, and you see, you put the elbow at 90 degree, and then you external rotate it. External rotate the shoulder. You are basically disimpacting the fracture. Okay. Then you slightly adduct and then internal rotate. So this will reduce the fracture and you will feel a click. And this is the Cocker method. And the posterior hip dislocation. So on X-ray, you will have a light bulb sign. Okay. Or you should have an axial view. See, this is a glenoid and this is a shoulder lying posteriorly. Okay. Now, how to reduce it? So this is the opposite of anterior dislocation. You give a traction and you internal rotate so that the fracture is the bone is disimpacted, and then you pull, and you can apply your assistant can apply a pressure over the head, and then you external rotate. And this X-ray is showing elbow dislocation. So this is a posterior dislocation, right? The relationship of the distal segment that tells us whether it is an anterior dislocation or posterior dislocation. So the distal segment is posterior. It's a posterior dislocation. And in AP you see the coronoid, it should be here. Okay. Polygonum should be here in the coronoid, but it's not. So you give a traction, you put a pressure, and it can be reduced. But this will require a sedation. So if you're suspecting joint and ligamentous injuries, so you will assess the patient, you will stress the joint to see if there's abnormal joint movement, okay? And also you will check the distal neurovascular status. So if you're suspecting some injury, you should immobilize the joint, and neurovascular examination is must. And you will consult an orthopedic surgeon for your opinion, okay? And sometimes the knee dislocation occurs, but it is reduced. And after that, the only finding will be ligamentous injuries. So you will have to check for that. You give varus or a valgus test to the knee, and you check if the ligaments are damaged. You check for the ACL or PCL injury. So fracture, what's fracture? It's a break in the continuity of the bone. Okay. And what are the clinical findings? You can have pain, swelling, deformity, okay, crepitus at the fracture site. And what should be the X-ray advised? So there's a rule of two. Two views, two angles, AP and lateral view, and involving two joints, joint above, joint below. And the fracture should be immobilized. It will reduce the pain and it will decrease the swelling. So, and surgery will be easier for the surgeon. What is the principle of immobilization? This is a very important thing. So, you immobilize the patient with a back slab. Okay. For upper limb, 12 to 14 layers. For lower limb, 16 to 20 layers. And after applying the back slab, you will again check the distal neurovascular status so that your slab is not impinging over any structure. So this is the box showing various slabs are applied in different type of flexors. In case of humerus, you apply U slab. Like in the wrist, you can have distal radius fracture or scaphoid fracture. So you apply different type of slabs. So first of all, in femur fracture, you apply skin traction and up to 2 kg weight, not more than 2. And skeletal traction, 5 kg weight. Okay. But if a patient has a floating knee injury, like he has a femur and tibia fracture, then you don't apply the traction, you apply the slab. So this is how skin traction is applied. You see, dressing, rolling, and then you put a weight over here. And this is how a skeletal traction is applied by giving local anesthetic at the distal tibia. You drill and you then apply the weight. And this is a common splint. If a patient has femur fracture but is not fit for surgery yet, then you can apply this traction. And when it's fit for surgery, you can do the definitive surgery. So this is how the weight is applied. So it should not touch the floor. If weight is touching the floor, the traction won't be helpful. So it should be above the floor like that. And the pressure area should be augmented with the cotton to avoid damage to the peroneal nerve and sciatic nerve. Knee mobilizer can be applied in case of a knee injury. This is the back slab of the knee. You see, so half the slab covering the posterior area only. You apply a cotton with 50% overlap. Okay, the slab is made from 16 to 20 layers. And then you apply the slab, 10-degree flexion at the knee, 90-degree at the ankle. So this is the cast in case of a tibial fracture. So you give above knee cast for 6 weeks, then convert into a PTP. Okay, that can be changed to a below knee after 12 weeks. Initially, you don't recommend weight bearing. Patient should be non-weight bearing. When the fracture is sticky, there is some union, then patient applies the weight. So this is a below knee cast. The pressure point should be covered with cotton and the cast should be molded so that the fracture is properly reduced. So this is how you apply a cast. You see there is 50% overlap of the cotton and also 50% overlap of the plaster of Paris. Okay, and in the end there is molding. And this is a slide showing how to apply a back slab. So you applied a stockinette and you applied the wool with 50% overlap. Okay, then you applied the slab and applied the crepe bandage. You can see 50% overlap. You can have a patient with clavicle injury and patient will have a fall on the outstretched hand. And the X-ray you should advise will be the shoulder AP view. Okay, so you see this is the fracture of the mid shaft of the clavicle. Okay, you apply a polyslip. And you can also apply these slings, the different type of slings that you can apply. Okay, if you don't have a proper sling, you can simply put a around the neck, okay, cuff and collar, and then if you have clothes like that, you can put it on the arm and fold it around the head. And in case of humerus shaft fracture, what are the options? So you can have U slab initially, and you can even have a hanging cast, okay? And when there is some union, you can apply functional humeral braids. Now, how to apply a back slab? Okay, it's a U slab actually. So in the shape of the U. So first of all, you apply the cotton. Okay, more in the axilla and covering the base of the neck. This is how you take a size. You apply the cotton, and you prepare the back slab, and you apply the back slab, and then you roll the crepe bandage. Okay. So this is a body bandage type dressing, and this is a U slab. In case of the elbow, so elbow should be splinted with what? With a back slab, the elbow in the 90-degree flexion, and forearm is in the mid-prone position, and wrist is in slight dorsiflexion, like cup holding position of the hand. So this is you apply a back slab in case of a elbow injury or radiation injury. Okay, this stockinette. Then you apply wool, cotton, 50% overlap. You wet the slab and this. You see the edges are covered with the cotton so that the slab don't touch the skin. And there is a layer of stockinette. Then you will fold it after. Then you apply the crepe bandage. So in case of forearm or wrist, you can apply a POP or a back slab. So this is showing a cast. So you apply stockinette, leave area for the thumb, and then you apply the cotton, then you wet the roll, and you apply the POP. Okay. So this is a Collis cast. And slight ulnar deviation. Okay. Molding is also done. This is a Collis back slab. Same position, but you apply back slab, the one side. So in case of hand, you can apply short arm back slab, ulnar gutter, radial gutter, thumb spica, scaphoid cause, depending upon the injury you have encountered. So what should be the position of the hand? Wrist in slide, dorsiflexion. And MP joint at 45-degree of flexion. It's like a cup holding position, right? So, see, cup holding position. Extension at the wrist, flexion at the MP joint. This is the cup holding position. It's called intrinsic plus position. This is the volar slab. You apply it from the front, volar surface. Other is dorsal slab. The volar slab, same technique. You take the size, okay? Wet the slab, you put the cotton, and you apply it. And if you have a undisplaced fracture of the finger that not involving the joint, okay, you can body strap. If you have fracture of the ring finger, you body strap it with the little finger, or the vice versa. But these web spaces should be covered, okay, with a gauze. And in case of mallet finger injury, you can apply a splint, mallet splint. In mallet finger injury, you have a injury to the dorsal area of the ligament here. So you have to use here, right here. So you have to keep it like that. So this is the ulnar gutter, okay. This is the radial gutter. So for the ulnar side injuries, like metacarpal, you can apply for fifth metacarpal, you can apply ulnar gutter. For the first, second, you apply radial gutter. And thumb spica. So it is a fracture, undisplaced fracture, not involving the joint of the first metacarpal, you apply thumb spica. Also, in case of the scaphoid, you have to apply scaphoid cast like that. So these are thumb spica slab. Okay. So what's the cast care? There can be a compression of the vascular structures or nerves when you apply a cast that's too tight. So you have to check the neurovascular status before and after applying the cast. Okay, and you will have to elevate the limb and you have to tell the patient that this can happen. Okay. And what are the missed injuries? There are some injuries that can be missed So you have to look for that. Okay. So this is a table that's showing that if you have fracture dislocation of the elbow, you can have an injury to the brachial artery or medial, ulnar, or in renal injury. So you have to look for that. In case of femur fracture, you have femur fracture, you can have fracture of the neck of the femur also. So you can have a knee injury, okay, or you can have a hip dislocation. So you have to examine these structures, okay. Likewise, in knee dislocation, you can have a popliteal artery or nerve injury, okay. And if your patient falls from the height, he will have a calcaneal fracture, and he can have a spine fracture. So you have to look for that. Okay. Thank you.